both have been around for over 40 years, Melinda Marinook and Hope Warshaw. They met each other in 1979 when they each started working as diabetes dietitians. As they started their careers, they soon realized there were not too many dietitians working in this field, so networking was really important to share ideas and get support. They were both founding members of the Academy of Nutrition and Dietetics Diabetes Care and Education Dietetic Practice Group, which also launched in 1979, Melinda editing the newsletter and Hope writing articles for it. This was a great way to keep dietitians up to date with research. It should also be noted that this group has now grown to over 6,000 members. Melinda Marinook is our first speaker. The title of her presentation is 1921 to the 1970s, Starvation Diets to the Exchange System. Melinda has spent over 40 years in the field of diabetes nutrition and education. Being a longtime employee of the Joslin Diabetes Center, she has always been fascinated by diabetes history. While officially retired, Melinda continues to consult with various diabetes-related organizations and also volunteer with her professional organizations, including the ADA, the Academy of Nutrition and Dietetics, and she currently serves on the board of the Association of Diabetes Care and Education Specialists.
Thank you to Allison and to the ADA organizers for suggesting this topic during the 100th year anniversary of insulin. I'm really delighted to address this topic with my dear friend and longtime colleague, Hope Warshaw. These are my disclosures. And while I have some formal objectives to identify the roles played by key individuals involved in insulin-era nutrition therapy and discuss some meal planning options, I mostly want to share some stories. I want you to sit back and think about both how far we've come and how history is repeating itself. And I'm sorry I can't be with everyone in person to go out for coffee or a glass of wine afterwards so I can hear your stories and memories and thoughts on this topic. So the topics I'm going to be addressing today include some thoughts about some of the nutrition leaders, meal planning approaches, the dietitian's role, as well as some remarks on education. So food and insulin, a life-saving combination. We've all seen images like these, young people holding on to life by severely limiting carbs and calories when food was the only treatment, and then being brought back to life through the miracle of insulin, thus allowing a return to eating enough calories to return to a healthy weight. In the 1950s, Elliot Joslin well captured not only the importance of the treatment triad, but also the critical role of the patient in self-management and the challenge of getting all three to work together when he said, "I look upon the diabetic as a charioteer, and his chariot is drawn by three steeds: diet, insulin, and exercise. It takes will to drive one horse, intelligence to manage a team of two, but a man must be a very good teamster who can get all three to pull together." That image that you saw for many years was the image on the 25-year medal awarded to those living on insulin for 25 years. Now, as you know, we have over 5,000 individuals who've received the 50-year medal for living with diabetes on insulin. And the number of individuals who have received a 75-year medal is 90. I've had a chance to interview some of these medalists, as well as some physicians who've practiced as early as the 1960s, and their stories have helped shape this talk. So I just wanted to share my appreciation for that. So when you think about early nutrition management in the pre-insulin and post-insulin era, we're not talking about going way back, but in the 1910s, 1920s, 1930s, what images, what words come to mind to you? What do you think about? And for me, I think about gram scales. I think about dietitians in maybe white uniforms and hairnets, weighing and measuring food. I think about very precise, specific diet plans. And being a longtime employee of Joslin, I think about the Joslin Manual, written for the doctor and patient, as it says here. When I think about words, I decided to ask a lot of people, nurses, dietitians, individuals who know people with diabetes, or how would you describe the eating plans of people with diabetes 50 to 100 years ago? And the words that kept coming up were things like restricted, measured, precise, difficult, very limited, very low carbohydrate, unpleasant, and not individualized. Well, I think some of this is true, but as I'll point out in a few minutes, when you ask the question, as compared to what, the early meal plans for many felt absolutely wonderful. So, a quick story from my own experience. I visited Camp Joslin several times in the late 1970s as a new dietitian. And I remember the boys taking the peach that they had for their lunch and carving off the flesh and weighing it on the gram scale until they got the precise amount that they were prescribed, usually about 100 or 150 grams of flesh. And then I moved to Florida, where I worked at the Florida Camp for Children and Youth with Diabetes. And their approach to meal planning was so different. Family style was the way foods were served in bowls on the table. It was healthy foods, and the kids selected what their appetite dictated, and they ate to their hunger level. And I learned at that point, wow, there is no one approach to meal planning and to nutrition for people with diabetes. Also, another quick story from one of the medalists. Many of you may know the name Paul Madden, and he shared a story at diabetes camp being given at least 4 pats of butter at breakfast or at a meal, because still then the diet was pretty high in fat. And he and the other campers would take those extra pats of butter, since you were only given 1 slice of toast, and stick it to the bottom of the dining hall tables. So instead of bubble gum, it was pats of butter that was under there. So a couple of questions for you. As you think about some of the what are now hot topics in nutrition, I think it's interesting to find out, when were they really first discussed? So the first question, when was information about diabetes prevention, calling attention to the importance of preventing and treating obesity, first published? Was it 1981, 61, 41, or 21? Now, you don't have the ability to click a button here. I just want you to think about the answer. And I'm wondering, are you surprised, as I was, to learn that it was 1921 when Elliot Joslin wrote an article on the prevention of diabetes, published in JAMA, and he wrote that there are entirely too many diabetic patients in the country, and diabetes is largely a penalty of obesity. And obese patients should be frankly told that they are candidates for diabetes. So the next question. Federal regulations for diabetic foods were published as early as 1950, 40, 30, 20. What do you think? Well, again, I was surprised to see a definition in 1920 that the term diabetic, as applied to food, indicates a considerable lessening of the carbohydrates found in ordinary products of the same class. Now, this was largely due to the fact that in the pre-insulin era, there were so many products being developed to allow individuals to have very low carb products, especially those made with flour. And they were flours that were high in gluten and protein and casein. One popular one was called Lister's flour. And it was interesting to me to find a dietitian writing back in that day, a number of more or less palatable breads may be made for diabetics, but the majority of the so-called gluten and diabetic flours are gross frauds, often containing as much as 50 or 60% carbohydrate. And lastly, when were dietitians first publishing about cultural foods and diabetes in JAMA? Was it 1970? Well, I'm going to just jump to the conclusion. And it was in 1927, which really surprised me. This is Frances Stern, a nutritionist who founded the Boston Dispensary Food Clinic, later known as the Frances Stern Nutrition Clinic, and writing an article that identified the importance of recognizing traditional food patterns and using national foods when treating patients with diabetes of foreign birth. And she wrote, a consideration of the environment, racial habits, and national customs is of more importance in the dietetic treatment of diabetes than in any other field of medicine. So I point out that history repeats itself because nobody listens the first time. So I want to highlight a few of the nutrition leaders, starting with Frederick Allen, who literally wrote the book on the starvation diet, about 1,000 pages worth. As a physician and researcher, his investigations with animals and then with people, both at Harvard and the Rockefeller Institute in New York, led him to recommend that a very low carbohydrate diet, which usually meant low calorie, would clear the urine of glucose and was the best way to extend life. His initial work translated into a set of practical recommendations in a small handbook called the Allen Starvation Treatment of Diet, where a 3-step approach was outlined by the authors, which included a physician and a dietitian who was at Mass General. And step 1 was very strict calorie reduction, where for 1 to 4 days, a diet of alternating with coffee and whiskey, 1 ounce every 2 hours, was consumed until the urine was free of sugar, followed by step 2, when they added thrice boiled vegetables for 1 to 2 days, and step 3, adding protein and fat gradually, because they discovered that when you add too much protein and fat, it really does increase the blood sugar levels, I should say the urine sugar levels. I'll point out that it was written that whiskey is not essential. It merely furnishes calories and keeps the patient comfortable. Thrice boiled vegetables, it was discovered that when you took the 5% or the lower carbohydrate vegetables, such as broccoli, and boiled them once and then tossed out the water again and tossed out the water, and then a third time and tossed out the water, you were tossing out much of the carbohydrate, thus rendering these already low carbohydrate vegetables even lower in carbohydrate. So Elizabeth Hughes was Allen's most famous patient, and she was diagnosed in 1918 at age 11, the daughter of a very prominent politician, former governor of New York State, who ran for president and also became the 11th Chief Justice of the United States. Dr. Allen is credited with keeping her alive on a diet largely of fat, bacon, butter, cream, and she functioned surprisingly well, in spite of having dropped from 75 to 45 pounds and living on a diet as low as 300 calories a day for 4 years, until she went to Toronto as one of the first recipients of insulin. Her first few months on insulin are detailed in amazing records that are archived at the University of Toronto libraries. And you too can read how she recorded her progress, both with insulin, her weight gain, and her diet. For example, she wrote in September 24th, 1922, the diet we struck was this 2512 calories with 63 grams of protein, 208 of fat, and best of all, 97 grams of carbohydrate. And she goes on to say, I must tell you what I had to eat yesterday. And by the way, she's writing to her parents. I had for breakfast 2 peaches, almost a whole shredded wheat with 4 ounces of heavy cream, an egg, bacon, cream cheese, lots of butter, and best of all, a whole slice of bread toasted. I love that part. And I could use up pages just in enumerating all the dishes I have nowadays. And it seems to me that I eat something every day that I haven't tasted for over 3 years. And you don't know how good it seems and how I appreciate every morsel I eat. Now, clearly, she would not have described her diet as limiting and restricted. So, being such a famous person, the newspapers picked up on this and highlighted the fact that she seemed to be cured. She was, amazingly well known at the time, and then she seemed to disappear. And so the question was, what did happen to Elizabeth Hughes? For after being so much in the media, she seemed to not have any connection with diabetes at all. It was as if her childhood defined by diabetes, she wanted to then live a life without diabetes being front and center, which is exactly what happened. And as it turned out, she lived an amazingly long life, as reported in a letter from her grandson, a physician in the New England Journal of Medicine in 1983, who shared these facts: that she was a college graduate, married, had 3 children, founded the Supreme Court Historical Society, died at age 73 with 62 years with diabetes and 58 of those on insulin. And he remarked on how seriously she took her disease, read about it a great deal, and diet, checked her urine regularly, and adjusted her insulin accordingly. Next, Elliot Joslin, who I think of as my mentor, spending so many years at Joslin Diabetes Center. I attribute him as actually sort of starting the concept of the diabetes educator, beginning with what he described as the wandering nurse. But certainly he was a big proponent of the weighed diets, measured diets in the post-insulin era. The diets were very moderate in carbohydrate, but they were included like weighed portions. A gram scale was very much a part of everyone's table. In fact, and it was very restricted in terms of the kinds of foods that were allowed. It wasn't so much exchange lists, but how much grapefruit, how much orange, how much oatmeal, bread, potato, egg, and cream could you have? It was written in one of the early Joslin books because grapefruit and oranges were really the only fruits in the early years that he was allowing. And it said, well, what should a diabetic do if they're given an apple? And the answer was, throw it away. And I remember one of my other early physician mentors, Dr. John Hare, saying that he recalls in the 1960s at Joslin Clinic, when the meals were served, he never saw such tiny apples that were allowed at that time to patients with diabetes. But he wondered, he said, I always wondered, where did they find those very tiny apples? All of the numbers in the early diets were such a big part of meal planning that they even had a chapter in the diabetic manual called Diabetic Arithmetic. And there were lists in the manuals for food values, which every doctor should know by heart. The doctor had a much bigger role in nutrition. The early meal plans were very structured, very measured. Dr. Arkey, one of my other mentors, Dr. Ron Arkey, tells me a story of George Minot, Dr. George Minot, who in the 1930s won the Nobel Prize, but had been diagnosed with type 1 diabetes and brought his gram scale right to the Nobel Prize dinner and put it on the table so he could weigh his food. The diets became progressively a little bit more adapted and individualized, allowing for, a bit more variation in quantity and food. The next person that I want to mention is Dr. Edward Tolstoy, who became most known for his publishing and writing and recommending what was referred to as the free diet. And the words at the bottom of his book, Living with Diabetes, speak about the modern diabetic treatment which permits normal living. And he very much was trying to pull away from people having to live with a gram scale on their table every day. And he wanted people to choose foods in quality and quantity that don't differ from the diet consumed by other members of the family, as long as it was overall healthy food choices. So he was not a proponent of weighed or measured diets. He said some desserts are fine, but avoid overindulging, avoid excess, but enjoy food more so you can feel like the rest of your family. There was a very famous debate in 1951 between Joslin and Tolstoy at the New York Academy of Medicine, where Tolstoy was very much the proponent of the free diet. But more than that, it was just putting less emphasis on tight control. And Dr. Joslin was very much a proponent of tight control. And a weighed diet was one way to get there. Now, we know the ultimate conclusion to that debate was concluded in 1993 with the results of the Diabetes Control and Complications trial. And many Joslin researchers and physicians in 1993 at the ADA meeting, when those results were announced, then sported a button that they put on their lapel saying, "I told you so," signed Elliot P. Joslin, who by then was long deceased, but his messages lived on. I also want to point out that there was a strong push to increase carbohydrate, not only by Dr. Tolstoy, but many other physicians were writing about how can we best ensure not only healthy and efficient lives, but comfortable and happy, normal ones, and a normal expectation of life, including Dr. Lawrence in London in 1933. The exchange lists came out formally in 1950, but that term exchange has been used for some time. And they were prepared jointly by ADA and the Academy of Nutrition and Dietetics and the US Public Health Service to really address the needs for standardization, because there was a great variation in food values and terminology, as well as an effort to simplify some of the nutrition messages. It was also very clear in this 1950s book the importance of individualizing, suiting special needs of the patient, and mentioning that meals should be worked out with the patient. So we really were seeing messages regarding individualization early on. The exchange list numbers back then looked very much the way they do now, only some slight changes. I also want to mention the role of the dietitian. I was surprised to see how often dietitians were mentioned and were used back in the 30s and 40s. Just as a reminder, the Academy of Nutrition and Dietetics, formerly known as the American Dietetic Association, had 1,000 members back in 1917. Dietitians were very much seen as recipe developers, co-authors of many of the diabetes nutrition texts that I have been referring to. The Mayo Clinic book had dietitian co-authors. Frederick Allen's team had what he described as his right hand for developing recipes, even during the starvation diet era. Incidentally, he did end up marrying Mary Bell Wishart, the dietitian. Joslin Clinic actually did not have dietitians until 1980, when myself and my wonderful colleague Beverly Halford were the first dietitians that were hired. But they had well-trained teaching nurses that were doing much of the nutrition teaching at the time. Interestingly, as I looked into Rena Ekman, who was the co-author of the Allen Starvation Diet book back in 1916, here in her obituary, they highlight the fact that she was a well-known dietitian. And I thought, wow, how cool is that? And in the Mayo Clinic primer that I mentioned, the dietitians were called out along with the physician co-author. A lot of recipe development, especially using some of these very low carbohydrate flours. Frances Stern, where I did my dietetic internship, I was surprised and delighted to see this picture book called Diabetic Care in Pictures, which very simply outlined food lists, was using the term exchanges well before the formal exchange list came out. Everything was presented in a very simple format. She was also the first to be recommending the concept of food models in teaching. She even had exchange lists for vitamins and minerals. Here are the calcium exchanges from the diabetes book that she published. In the 60s and 70s, as we know, the calorie levels were fairly structured. Meals and snacks were divided, or is recommended be divided by percentages so that you had equal divisions between meals and snacks. The unfortunate period in our history was when, in the effort to try to be convenient, we developed all these tear-off pads, and it was too often patients were handed just a not individualized sheet that said, okay, here's what you need to eat to be on an 1,800 calorie ADA diet or so forth. Final wrap-up comments, the importance of education. Joslyn had a long-time diabetes treatment unit where Joslyn is well known for saying the diabetic who knows the most lives the longest. But I really chuckled when I was reading in the Mayo Clinic book back in 1940, Dr. Wilder said that there are 127 questions that patients attending diabetic school are required without prompting to answer before they are willingly dismissed. And to ponder the statement that was put forth by Eric Westman recently in an article, the rapid adoption of insulin therapy and the hope that it would cure diabetes may have led to the premature abandonment of early successful nutrition treatments. I had wonderful conversations with many individuals who've lived well with diabetes for more than 50 years. And invariably, the most important message that came across that they had was that they had incredible family support. They were on a variety of initial diets, from free to weighed. They all agreed it was a tremendous amount of work, but they all reported on how grateful they were for their families and to be living through the many advances in nutrition care. Physicians that I spoke to said unanimously they were grateful for dietitians and for diabetes educators to help with their roles. So what I learned was history does repeat itself. There are multiple approaches to meal planning. Nutrition research did seem to take a backseat after insulin. Individualization and patient satisfaction were important. Family support was valued. Dietitians were involved, and we have come a long way, and we keep getting better. And I close with a quote from my dear mentor and colleague friend. There's no such thing as a diabetic diet. Dr. Arki was saying this back in 1980. And now I look forward to Hope Warshaw bringing us forward. Oh, special thanks to all of those who did contribute their thoughts with me about living well with diabetes and nutrition. And so we look forward to Hope bringing us forward to present day. Thank you very much.
Our second speaker is Hope Warshaw. The title of her presentation is The 1980s to 2021, Prescribed Macronutrient Percentages to Person-Centered Approaches and Beyond. Hope, who has spent her career involved in diabetes care and management, has a particular focus on nutrition management. She began her career in Atlanta, Georgia, where she was a dietitian in the Grady Hospital Diabetes Unit under John Davidson, MD. Dr. Davidson, who had type 1 diabetes himself, was a big supporter of the role of nutrition in diabetes management. After working in various diabetes and obesity management clinical settings, Hope began her business, Hope Warshaw Associates, which she continues to operate today. Within her business, Hope has stayed diabetes focused and has applied her skills in her work as a consultant, book author, freelance writer, and media spokesperson. Like Melinda, Hope has also spent time as a volunteer with diabetes-related organizations, including the Academy of Nutrition and Dietetics, the Association of Diabetes Care and Education Specialists, and the ADA. I will end by saying both of these women have also mentored countless dietetic professionals over the years in the field of diabetes nutrition, including myself.
Thanks to Allison Everett for the kind introduction. I'm delighted to take over from my colleague and friend, Melinda Marynook, and present the second half of this mini symposium. I'll cover from the 1980s and end with a few thoughts about the future. Photography is allowed. Care was taken to use freely available photos and graphics or to get permission to use them. I cannot be absolutely sure of this in all instances. However, this content is intended solely for educational purposes. These are my disclosures at the present time. During this talk, I'll use names of several diabetes-related organizations and clinician types. Over the last couple of years, there have been several organizational and clinician name changes. I'll use the most current names and titles throughout. For a bit of personal perspective, I'll share that I began my career in 1979 as a registered dietitian in diabetes care, and I never left diabetes care. My first job was at the famed Grady Memorial Hospital's diabetes unit in Atlanta. It was at that time under the leadership of Dr. John Davidson. He had type 1 diabetes and at one point trained under Banting and Best. I've noted a few characteristics about diabetes care from that era. Speaking to limited medication options, a particular feature I recall is that due in part to the results of the University Group Diabetes Program study, Dr. Davidson did not allow the use of sulfonylureas. Thus, insulin was the only glucose-lowering medication used. At the diabetes unit, nutrition management played a significant role. We counseled mainly Black individuals with type 2 diabetes. Interestingly, we used 7-day fasts aimed at breaking glucose toxicity. Post-fast, we counseled people on using a protein-sparing modified fast. As we're celebrating the 100-year anniversary of the discovery of insulin, I will note where we were in the progression of insulin development in the late 1970s and early 80s. Lily has put together an excellent slide deck recapping this history. I've highlighted in 1977, we saw the elimination of U40 and U80 insulins, and in 1982, we saw the first human U100 insulins. Also in this slide deck from Lily is a discussion of other glucose-lowering medications. In the early 80s, we had first-generation SFUs, and in the US, the biguanide metformin was not approved for use until 1995. Since then, there have been many glucose-lowering therapeutics added to our armamentarium, as noted in this slide. I want to make the overarching point in this slide that as we observe the evolution of diabetes nutrition management recommendations and practices over the years, we must recognize that these have been and continue to be impacted by the entire surrounding ecosystem. A number of these factors are noted on the slide. A few that I believe have greatly impacted diabetes nutrition recommendations and practices are our knowledge of the pathophysiology of the types of diabetes, and for sure, the development of numerous glucose-lowering medications, including insulins, specifically related to food availability, as well as eating styles and patterns, has been societal changes and the evolution of food and nutrition policies. To a recap of what occurred in the 1980s in diabetes nutrition recommendations and care. A late 1977 research study conducted by dietitian Phyllis Crapo changed thinking about the advice to treat sugary foods and sweets as forbidden and to recognize that various sources of carbohydrate impact glucose differently. Crapo and colleagues fed equal oral carbohydrate loads to normoglycemic, people with diabetes, or people with impaired glucose tolerance after an overnight fast. The sources of carbohydrate were rice, potato, corn, and bread. Blood samples drawn over 3 hours showed blood glucose and endogenous insulin responses after eating potato were essentially identical to those from oral glucose. Rice and corn ingestion resulted in much lower blood glucose responses. bread resulted in glucose and insulin responses that were between potato and rice. These results led to some rethinking. In each decade, I'll offer a few key landmarks and highlights and review the ADA nutrition recommendations of the time. I've referenced a wonderful history of diabetes nutrition through the early 90s, written by Maggie Powers. We saw a number of firsts in the 1980s. The first dietary guidelines for Americans were published by the US government. Over the years, the dietary guidelines have factored into the ADA nutrition recommendations. In 1983, ADA published the first national standards for diabetes patient education programs. These standards continue to be revised about every 5 years, and there is a revision of these going on at the moment. In 1986, there was another revision to the exchange list for meal planning and the development of an easier to use meal planning tool, Healthy Food Choices. Several other landmarks and highlights of note. The certification board for now CDCESs was founded, and the first exam was given in 1986. I took the first exam. Blood glucose monitors were getting smaller and faster, though not by today's standards, and more people were doing so-called home or self-glucose monitoring. 2 studies were initiated, the DCCT and the United Kingdom Prospective Diabetes Study, or UKPDS. These studies had and continue to have impact on diabetes care. The DCCT continues today as the EDICT study. Of societal note, the numbers of people with overweight and obesity began to rise dramatically, and in response, so did the rates of type 2 diabetes. A group of about a dozen diabetes nutrition experts drafted the 1986 position statement. I've noted a few key points of this iteration. Individualization remained a cornerstone. The percent of calories as carbohydrate was set at the highest amount ever to date at 55 to 60%. This was likely due to the Crapo et al. Research I shared about the different impacts of carbohydrate sources. The change was also likely due to the work of physician James Anderson and dietitian Cynthia Chandler on the benefits of high fiber intake on glycemia and insulin response. Note was made that this guidance was similar to other key health organizations as well as the dietary guidelines. Interestingly, this edition of the position statement was 6 pages in length and contained no references. For comparison, the current 2019 consensus report is 24 pages and has over 300 references. As a way to share others' perspective and pay homage to several trailblazers in this field, I'll share a few quotes along the way. I placed Judy Wiley-Rossett's quote here because she was one of the 11 authors of the 1986 nutrition recommendations. Judy has been a leader in this field for over 50 years. She shared during the 1970s, nutritional epidemiologists investigated selected nutrients in foods as predictors of specific health outcomes. Today, epigenomics and metabolomics are informing precision nutrition. Additionally, investigating social determinants of health related to obesity and diabetes disparities offer insights for developing intervention trials and informing health policy. On to the 1990s. I'll touch on a few key landmarks and highlights from these years. UKPDS was completed and the DCCT results were unveiled. In fact, they were unveiled at an ADA meeting, and I still remember being in a packed auditorium for this and really exciting announcement. In 1995, an outcome study conducted by Franz et al. On the effectiveness of medical nutrition therapy in type 2 diabetes was published. More about that in a moment. coverage for diabetes self-management education and support for all people with diabetes was signed into law by President Clinton in 1997. As part of the same Balanced Budget Act, Congress recommended an Institute of Medicine study to consider the research on adding a Medicare benefit for MNT. The Diabetes Prevention Program study was initiated towards the end of the decade, and the Diabetes Dietetic Practice Group and the Academy published the first versions of the nutrition practice guidelines for type 1 and type 2 diabetes. An important nutrition-focused ancillary study from the DCCT was published in Diabetes Care in 1993. Two dietitians, Belle Halford and Linda Delahunty, with nearly 700 of the intensively treated participants, set out to identify diet-related behaviors that appear to assist these people in achieving their lower A1C. They identified 4 diet behaviors as noted on the slide. In conclusion, these authors encouraged clinicians to promote these impactful behaviors to simplify self-care while simultaneously improving management. We can point to the DCCT study as to when the use of carbohydrate counting as a meal planning approach gained interest and momentum, particularly for people using MDI or insulin pump therapy. This quote is from Linda Delahunty, co-author of the study I just reviewed. Linda has been involved with several of the large diabetes nutrition-focused NIH-funded studies. She's been a champion for the role of the dietitian in nutrition research. Linda said, in the DCCT, we learned intensive therapy alone was not sufficient to achieve glycemic targets. We learned the role of the RD, or RDN as we use today, and careful attention to diet was key to achieving glycemic targets in intensive diabetes therapy without undue hypoglycemia or weight gain. Speaking of champions and trailblazers in diabetes nutrition management, I must pay homage to our colleague, Marian Franz. Marian impacted this field for decades and well into the 2000s. In 1995, with support from the Academy and DDPG Outcomes Grant, Marian and her colleagues at the International Diabetes Center studied nearly 200 people with type 2 diabetes for an average duration of 4 years. They compared usual nutrition care to more intensive care, which was defined as 3 or more visits with an RD. This outcome study showed that with intensive nutrition intervention, people who had been diagnosed less than 1 year had a decrease in their fasting plasma glucose of 50 to 100 milligrams per deciliter. Their A1C decreased about 1 to 2%. Of particular interest, this study also showed that the effectiveness of MNT on A1C was seen by 6 weeks to 3 months. In people who didn't have a significant lowering of A1C, the RD recommended the use of glucose-lowering medication to their physician. Soon after this study and others had been published, a group of colleagues I teamed up with wrote several publications documenting this evidence, including the article referenced here, published in Diabetes Care. This slide, developed by Marian and shared by Alison Everett, factors in the effectiveness of MNT data and the results of the UKPDS, demonstrating that type 2 diabetes is a progressive disease and that metabolic control matters throughout. This slide promotes the value of nutrition therapy in prediabetes when insulin resistance develops and throughout the course of type 2 management. The next ADA nutrition position statement was published in 1997. The following are a few key points. Again, we see the words individualized and person-centered. For the first time, the term metabolic management is used. Also, for the first time, there's focus on decreasing the consumption of saturated fat with the recommendation to divide the remaining 60 to 70% of calories as carbohydrate and monounsaturated fat. The concept of considering medication to promote weight loss in tandem with nutrition management was introduced. Of note, this iteration of the nutrition position statement was 4 pages and contained 3 references. This strong statement appeared in this position statement. Quote, today there is no one diabetic or ADA diet. The recommended diet can only be defined as a dietary prescription based on nutrition assessment and treatment goals. Here I'll recap the history of the nutrition facts label under the direction of the US FDA and USDA. Though not diabetes specific, the availability of nutrition information has been extremely valuable to people with diabetes and clinicians. Prior to 1990, limited information was included on foods and beverages. The Nutrition Labeling and Education Act was signed into law in 1990, yet it took 4 years until 1994 to write the regs and have them implemented. No change was made to the label for 12 years until 2006. The only change at that time was to add a line for trans fat. Then in 2016, the most significant overhaul to the nutrition facts label was signed into law by President Obama. These changes were finally implemented just recently in 2020. An often discussed aspect of this overhaul was the addition of added sugars within total carbohydrate. The framework for the restaurant nutrition facts were actually part of the Affordable Care Act, but did not go into effect until 2018. The next trailblazer quote is from Maggie Powers. Back in the 1990s, she twice edited the book in the slide, the Handbook of Diabetes Medical Nutrition Therapy. I believe that's the cover from the second edition. Maggie shared, so much has happened, but so much has stayed the same. While advancements in medicine and technology offer more tools, person-focused nutrition therapy, which includes understanding how a person makes food decisions and supporting people in meeting their health goals, remains foundational to care. On to the 2000s. The 2000s were marked by numerous landmarks and highlights. A few are detailed here. Medicare coverage for diabetes self-management education and support went into effect in 2000, and MNT went into effect only, though, for people with diabetes and or those with chronic kidney disease. The Look Ahead trial to determine the impact of weight loss on cardiovascular disease in people with type 2 began in 2001. In this decade, the DPP was stopped early and showed positive results in reducing the risk of incidence of type 2 diabetes from intensive lifestyle intervention. The DPP was continued as an outcome study as DPPOS starting in 2002 and continues today. In 2002, the CDC was authorized by Congress to translate the results of the DPP and scale the national DPP. 2 other sets of nutrition recommendations were published in this decade. To a couple of points about outcomes from DPP. The amount of weight loss was found to be the dominant predictor of reduced incidence of type 2 diabetes onset and diagnosis. In counseling, I refer to weight loss as winning the award for best leading role for preventing or slowing the progression of prediabetes and potentially putting prediabetes or type 2 diabetes into remission. Physical activity was shown to be important, but it was more influential in helping to sustain weight loss. I say it wins the award for best supporting role. As mentioned, the ADA nutrition position statement was updated twice during the 2000s. I'll note a couple changes from past sets of recommendations we've reviewed. So in 2004, levels of evidence were added to this publication, and types of carbohydrate to consume were given A-level evidence. Due to the growth of overweight, obesity, and related onset of prediabetes and type 2 diabetes and study outcomes, there was increased focus in the weight management area. The position statement was again updated in 2008, and I have to confess, I don't know why. Again, I'll note a couple of changes. This was the first time we see the words, "there's no optimal macronutrient mix," and we continue to see that language in today's guidance. Emphasis was placed on minimizing trans fat consumption and increasing intake of fish for their omega-3 content. And all of these changes related to fats reflects the general nutrition concern and research and guidance of that time. A note about bariatric surgery for weight loss was added. And lastly, a recommendation was added to help prevent the progression to type 2 diabetes with a structured lifestyle change program a la DPP. I found this prescient quote by Lynn Wheeler in a 2000 article in Diabetes Spectrum. Lynn made many, many contributions to this field and was for sure a trailblazer. In this article, Lynn stated, diabetes nutrition recommendations have witnessed cycles between greater or lesser amounts of specific foods, food groups, and or macronutrients. In this new millennium, we will break this cycle by focusing on the process of medical nutrition therapy to help people meet individual goals rather than one-size-fits-all recommendations. How will this happen? Lynn asks. Quality research, she says. Independently based on a wide variety of patient population needs, from literacy to language to cultural food practices and more, an array of teaching resources have been developed over the decades. These covers on the slide represent merely a scant few. On to the 2010s. Several key landmarks and highlights are noted. I think we can agree that the entry of continuous glucose monitoring and related advances over the decade have been a highlight. Clinicians are using this data to assist people with diabetes to more closely understand and manage their glycemic trends, food choices, and amounts of foods they eat. In 2012, Look Ahead was stopped early. Though initial headlines suggested minimal benefits in reducing CVD, a number of health and lifestyle benefits have been determined. In 2014, the Direct UK 2-year study was started. This study, conducted in PCP offices, looked at the impact of significant weight loss to result in remission of type 2 diabetes in those with early onset type 2. The nutrition practice guidelines I mentioned earlier were revised in 2017. And in 2018, Medicare added coverage for the Medicare diabetes prevention benefit. In 2013, ADA published another nutrition position statement. For the first time, the authors were listed. This iteration indicated that these recommendations were only for adults with diabetes and not for the pediatric population. We observed several consistent themes from past recommendations, including individualization and promotion of healthful eating that is aligned with the US dietary guidelines. I'll call out 2 new additions. The statement, maintain the pleasure of eating, limit food choices only when indicated by scientific evidence, and recognition that people need practical tools for day-to-day planning and eating, from reading that nutrition facts label to choosing healthy restaurant foods and many more topics. To another trailblazer, our monitor for this session, Allison Everett. Allison co-chaired the 2013 and 2019 ADA nutrition recommendations and has done much more to support the value of nutrition management in diabetes care. Commenting on the two sets of recommendations she was involved with writing, she says, evidence does not support a clear preference for any specific eating plan or macronutrient range for weight loss. A variety of eating plans are effective. Total energy intake versus macronutrient source of the energy is of greatest importance, and what the person is willing to follow long term. To our current decade, of which we're in the early years, I placed the current nutrition guidance published in mid-2019 within this decade. As you may realize, ADA is no longer publishing position statements. Thus, this publication for the first time is referred to as a consensus report. It covers adults with prediabetes or diabetes. As usual, the current nutrition therapy guidance document is briefly integrated into Section 5 of the ADA's annual standards of care, as well as ADA's living standards initiated just a couple of years ago. As mentioned earlier, this publication is 24 pages and contains over 300 references, quite a difference from 6 pages and no references in 1986. The 2019 consensus report has 4 key goals. These reiterate the message of promoting healthful eating, choosing nutrient-dense foods and appropriate portions for overall health, not simply diabetes care. More than ever before, clinicians are encouraged to base nutrition guidance on aspects of the individual, on all aspects of the individual, from their literacy to cultural food preferences and personal barriers to behavior change. Goals 3 and 4 reiterate points seen in the 2013 recommendations about maintaining the pleasure of eating and providing people with practical, everyday tools. New to the 2019 consensus report was a more extensive evidence review of a wide array of potential eating patterns or eating styles for people with diabetes. This extensive table in the report describes each eating pattern and cites potential benefits in the literature. The 2019 nutrition guidance summed up what I call the 4 common denominators of a healthful eating pattern that people can follow either with prediabetes or type 2. So much teaching and goal setting can be done focusing simply on these 4 common denominators without even delving into a specific meal plan or meal planning approach. As I began, I noted these many factors that have and will continue over time to impact the evolution of guidance on diabetes nutrition therapy. As our knowledge, society, and technologies evolve, so must our nutrition guidance. Listed on this slide are concepts and knowledge areas I and other colleagues I connected with for this talk project will impact future diabetes nutrition therapy guidance and management. As you see, there are a wide range of topic areas, from mindful eating practices to concerns for our planet, to precision nutrition, to the role of the gut microbiome, and to the ever important challenge of optimizing behavior change strategies for success. I leave you with these as food for thought for the future. Last, I want to thank and congratulate the many colleagues and friends who have contributed their great minds, countless hours, and tremendous passion to advance the nutrition management of diabetes care. Melinda and I appreciate the opportunity to walk down this memory lane with you. It's been fun. We all hope you have an excellent 81st ADA scientific sessions. Thank you.
Thanks, Melinda and Hope, for this very informative presentation. And thanks to the participants for choosing this session.